Thank you guys for having me. It's a pleasure being here in Saudi Arabia among friends and peers. I'm going to try to concise this in 15 minutes. So if I go overboard, let me know. So the heart of the matter, understanding cardiac risk in MASLD patients. These are my disclosures. So introduction. MASLD is a chronic liver disease with a rapidly rising global prevalence. Almost 1/3 of the global population has one form of fatty liver disease. Different parts of the world have even more than that. It's a multi-system cardiometabolic disease that increases the risk of extrahepatic complication. Cardiovascular disease is the leading cause of mortality in MASLD, surpassing liver-related causes. There is a strong association exists between MASLD with atherosclerotic heart disease, heart failure, and cardiac arrhythmias. The close relation between steatosis, steatohepatitis, and metabolic syndrome, including central obesity, diabetes, hypertension, and dyslipidemia, largely mediates the increased cardiovascular risk. So is this a causation versus correlation syndrome? Accumulating evidence support that MASLD is an independent risk factor for new cardiovascular disease. So MASLD and mortality risk. If you look at the mortality risk in liver disease in MASLD, all-cause mortality is 12.6 per 1,000 person years. If you look at liver-specific mortality, 0.92. Extrahepatic cancers, 2.8. That's all outshined by cardiac-specific mortality, which is 4.2 per 1,000 person year. So basically, cardiovascular disease, not liver disease, is the dominant cause of mortality. MASLD is an independent risk factor for cardiovascular disease. It's increased morbidity and mortality, or it's an independent risk for morbidity and mortality. And this was supported by large population-based studies. There's a Swedish nationwide cohort, Simon et al. They looked at 10,400 patients with histologically confirmed MASLD. These patients all had liver biopsies and had 50,000 controls, followed them for almost 14 years. And the outcomes, they looked at the events of chronic heart disease, strokes, heart failure, and cardiovascular death. The main findings, MASLD disease, MASLD was associated with significantly increased cardiovascular disease risk. And that was independent of traditional cardiometabolic risk factors. Cardiovascular risk increased with worsening liver histology. So the worse their liver fibrosis, the worse their risk for cardiovascular disease. Non-cirrhotic fibrosis had a hazard ratio of 1.67 of developing cardiovascular disease. Cirrhotic patients had even a higher risk. So more fibrosis, as the disease progresses, it actually precipitates more cardiovascular disease. So it's a progressive increase in cardiovascular disease, again, independent of traditional risk factors. This is a meta-analytical classification of the excessive risk factors for developing fatal and non-fatal cardiovascular disease. And this is Mantovani in 2021, 36 different longitudinal cohort studies, about 5.8 million patients over a period of about 6.5 years. And any fatal or non-fatal cardiovascular events was 1.45 hazard ratio of developing cardiovascular disease. Fatal was 1.3 and non-fatal was 1.4. So what's the pathophysiology? Again, is this causation versus correlation? So it's not really causation. It's not really correlation. It is causation. The heart of the matter, keeping with the theme of the topic, is inflammation. With insulin resistance and lipotoxicity that in the liver, causing MASH and eventually causing liver cancer, there is an increase in innate immunity and pro-inflammatory cytokines are released. Increase also in adaptive immunity with all the cascade of events. That all leads to inflammation. And now we have to include gut dysbiosis and gut microbiome in everything right now. And so gut microbiome because of the introduction of the pro-inflammatory diet, a lot of fried food, a lot of processed food, a lot of preserved food, that all increase the inflammatory status, which actually leads to increasing strokes and heart failure and other cardiovascular disease and other complications. So the relationship between MASLD and cardiovascular disease is a bidirectional and mechanistically complex, with insulin resistance causing chronic inflammation and vice versa, and that leads to oxidative stress, which in turn leads to endothelial dysfunction, and it's all kind of a vicious circle kind of feeding off each other with MASLD and cardiovascular disease kind of affecting each other. So basically, it's a shared pathophysiology of insulin resistance, chronic inflammation, oxidative stress, and endothelial dysfunction. And if we look at that a little bit closer, so NAFLD and MASLD or hepatic fatty liver disease in general, there's a lot of insulin resistance, oxidative stress, lipid abnormalities with atherogenic properties, dysregulation of the coagulation cascade, long-standing systemic vascular inflammatory process, ectopic pericardial fat, increasing the pro-inflammatory adipokines, endothelial dysfunctions, which leading to decreased nitrous oxide release and increasing the vascular resistance and platelet activation, gut microbiome dysbiosis, and genetic alterations. All leads to the different kinds of cardiovascular events with atrial and ventricular remodeling and myopathy, electrical and autonomic remodeling, and coronary atherosclerosis and plaques formation, leading all to heart failure, atrial fibrillation, and different other arrhythmias, and ischemic heart disease. So, looking at the epidemiological evidence, key findings, MASLD is associated with an accelerated coronary atherosclerosis. But not only that, it also affects multiple anatomical structures, affects the left ventricle, causing diastolic dysfunction, affects the left ventricle, also causing hypertrophy, cardiac valvular calcifications, and different arrhythmias, especially permanent atrial fibrillation, which is the most prominent ones. And so MASLD is a systemic cardiometabolic disease that again affects the entire heart, not just the coronary arteries. So if you look specifically about in the three main cardiovascular events that happens with these patients, arrhythmias, MASH is increasingly recognized as an important contributor to cardiac electrical instability. There is a strong association between NAFLD or MASLD and cardiac arrhythmias, including atrial fibrillation, most common one, QT interval prolongation, ventricular tachyarrhythmias, and PACs and PVCs. So atrial fibrillation risk in NAFLD, and this is a meta-analysis looking at I think about 67 different studies over the course between 2017 and 2025, about 20 million patients altogether, and the median follow-up was up to 24 years. And the clinical cardiovascular outcome they were looked at was incidence or prevalence of atrial fibrillation. And if you look at all the studies, every single one of them showed the increased risk of atrial fibrillation in these patients with a hazard ratio ranging between 1.2 and 2.1, depending on the study and the population. Framingham study, and this is a very famous cardiac study that was published in the early 2000s. And one thing they noticed that patients with elevated AST and ALT had a 1.12 and 1.19 hazard ratio of developing atrial fibrillation, independent of other risk factors. And this didn't really look at pathophysiology. This is just looking at the attributes of these patients developing atrial fibrillation. And this was a 10-year follow-up for over 3,700 patients. About cardiac coronary artery disease risk in MASH patients. So almost half of MASH patients will have atherosclerotic disease, coronary artery disease. Looking at 67,000 patients with NAFLD, there was an increased risk increased odds of developing coronary artery disease in NAFLD patient as opposed to non-NAFLD patient who was 1.3 odds ratio. That was reported in clinical gastroenterology and hepatology in 22 by Toe. So the role of gut microbiome in MASLD and atherosclerosis is kind of complex. In MASLD, there's a disrupted cholesterol and triglyceride metabolism. There's dyslipidemia, there's atherogenesis, and plaque formation. But the gut dysbiosis leads to formation of a lot of toxins and formation of the now famously known gut-liver-heart axis, and increasing risk of cardiovascular disease. About heart failure, there is a meta-analysis of 11 longitudinal cohort studies looking at over 11 million middle-aged patients, and it was there was a pooled hazard ratio of 1.5 risk of developing heart failure, and that was independent and that was consistent across all patients with different risk factors for heart failure, including type 2 diabetes, hypertension, and other risk factors. That was again versus corroborated by a propensity score matched outpatients in 2 large cohort studies looking at 175,000 patients. The 10-year had a 10-year higher cumulative incidence of heart failure of 1.3. So this is the pathophysiology, this is the epidemiology. So now looking at the clinical aspect of things, looking at the, when I look at my liver patient, who are the patients who are at higher risk of coronary or cardiovascular disease? There's modifiable and non-modifiable risk factors. Modifiable risk factors, as you can imagine, or the non-modifiable risk factors, as you can imagine, older age, men, strong family history of premature coronary vascular disease, 13 ethnicities, specifically South Asians, early menopause before the age of 40. Modifiable risk factors, patients who smoke, elevated LDL cholesterol, physical inactivity, unhealthy diet, abdominal obesity, where they have body weight of, in men over 38 pant size, or that's about, I think about 92 centimeters, hypertension, insulin resistance, atherogenic dyslipidemia, and type 2 diabetics. So how do I manage these patients? Patient comes in today, has MASLD. We assess the cardiovascular risk factors, looking at their diabetes, hypertension, dyslipidemias, high cholesterol, high LDL, low HDL, high triglycerides, look at smoking, other risk factors that we just discussed, and then estimating their cardiovascular risk using the region population specific scoring tools like the Q-Risk-3, SCORE-2, or SCORE-2 diabetes. If the patient has additional diagnosis requiring specific treatments, like type 2 diabetics or chronic kidney disease or hypertension or known prior cardiovascular disease, you target that, and I'm not going to go in details for the interest of time. If you're using a score and they have a 10-year increased risk, then you can actually straight go to statins, and as we know, statins are safe in our cirrhotic patients. They actually even help with portal hypertension. You can also, if the patient has very high risk of cardiovascular disease or symptomatic or intolerant to statins, you can do a high-resolution CT scanning and estimate the calcium scores. About how can we improve the liver? We said that the liver is the reason that these patients, MASH or fatty liver disease is the reason that these patients get cardiovascular disease. So if they have hepatic, we have to target hepatic liver fat reduction by lifestyle modifications, bariatric surgery, PPAR receptor agonist, incretin or GLP-1 agonist, SGLT inhibitors, and thyroid beta receptor agonists. We actually also have to improve NASH improvement, or and our holy grail is resolution of NASH. Again, lifestyle modification and plus minus bariatric surgery or weight loss in general, and you're going to find that the common denominator in all targets. PPAR receptor agonist, again GLP-1 agonist, and beta receptor agonist, thyroid beta receptor agonist. Fibrosis improvements, lifestyle modification, again weight loss through bariatric surgery, PPAR receptor agonist, thyroid hormone receptor, beta receptor agonist. So coming to my last slide, just kind of tying everything all together. If you look at the risk factor for MASLD or the epidemiology, pathophysiology, there is genetic factors, there's dysregulation of the coagulation cascade, there's long-standing systemic and vascular inflammatory process, insulin resistance and oxidative stress, lipid accumulation and dyslipidemia, ectopic epicardial fat, endothelial dysfunction, and gut microbiome dysbiosis. All leads to atrial ventricular remodeling and myopathy, electrical and autonomic remodeling, and coronary artery disease, atherosclerosis, and plaque formation, leading to the 3 most common events: ischemic heart disease, atrial fibrillation, and heart failure. Managing these patients, we have to precision diagnostics, we have to genomic profiling, imaging, and using artificial intelligence and blood-based biomarkers and multiomics. To better stratify our patients, looking at trying to estimate their cardiovascular risk, who's going to progress from MASLD to MASH, predicting the therapeutic response, and looking at different patient phenotypes, and and that will lead us to precision therapeutics with target pharmacotherapy and personalized lifestyle intervention. Who needs to exercise more, who needs to need to do more cardio, who needs to adjust their diet, who needs to lose 5% of their body weight, who needs to lose 10% of the body weight. And then finally, the final outcome is improving our patient outcome in our MASH patients. That's